Sorry. It did take us a while to get down here, so we're like 5.
Oh, I'm hoping you're going to be forgiving just because it's my first time trying to do all this.
I didn't even notice. So.
Yeah, we were just worried we weren't in the right spot. She gonna come get us?
You guys did fine. Okay, so go ahead and get out your tickets if you would, if you have them. Otherwise, I'll remind you of the questions if you don't have yours right in front of you. So, what we're going to do today is sort of a crash course in postpartum nursing. And we'll talk a little bit about newborn stuff, but we're going to talk about postpartum in lecture next week. But I wanted to kind of do some of the hands-on stuff that you'll see and touch and feel in clinical. I think sometimes when we lecture, it sounds nice, but seeing and touching and feeling helps a lot if you're a tactile learner. Okay, so let's start at the beginning. I think the first question is, what is a C-section? So why might somebody need, well, what is a C-section, first of all?
You have to make an incision through the stomach or into the uterus to take the baby out.
Okay. So it's basically, go ahead, does somebody else need to say?
Yeah.
Can be planned or unplanned. What are some reasons we might do a C-section?
If the baby or the infant is in the wrong position.
Okay, like what
Their
position?
breech or...
Okay, their breech, yep. They used to deliver babies breech, but not as much anymore and not usually planned. Usually if they come out breech, it's not planned. Okay, so malposition, what else?
I put if the mother has an active, like, genital herpes or HIV
Mhm.
positive.
Sure.
If there's a placental abrasion.
Abruption.
Yep. Abruption, yeah. Sorry.
Abruption, yep.
Got it wrong.
That's okay, we haven't talked about that yet. So placental abruption is when the placenta starts to tear away from the uterine wall before the baby's been delivered. So it's like going in the wrong order and it's a crisis situation.
Prolapsed umbilical cord.
Okay, prolapsed umbilical cord.
Destatting of the baby.
Yeah, usually we call it fetal distress. So if the heart rate is telling us, the heart rate usually tells us how well oxygenation is going. So if the pattern looks like the baby's in distress, especially if we try a few maneuvers and it doesn't work to fix that, then they may do an unplanned C-section for that. And then there's some other reasons, like if there's multiples, triplets, quadruplets, twins you can try for a labor if they're both head down, but usually if they're in different positions or not in a position that's favorable, they'll do a C-section.
They always hear the liver in the OR still.
The twins?
The twins.
Yes, they usually, if they're gonna labor them, they'll still labor them in the OR. I've only taken care of a few women, but that have had one vaginally and then the other C-section. I always feel so sorry for them. And that's why when we talked about it, that only counts as one para. Mm-hmm. I'm like, I feel like if they have a C-section, vaginal delivery, that should count as 2, but it doesn't. But yes, that's to answer your question, yes. Okay, anybody else have any other reasons listed?
If the mother has like hypertension or has pre-existing cardiac disease.
Yeah, sometimes, so sometimes if there's like, which we talked about cardiomyopathy, right, and other cardiac conditions being a problem, if they're afraid that the act of laboring or pushing will be too stressful for her cardiovascular system, they'll sometimes do a C-section for that. And then some of them are planned because they're what we call repeat C-sections. So a lot of times if a mom has already had one, the provider will just say, do you want a C-section again? Okay, what date? Other times they'll allow them to try to labor if they would like to do that. But if it's just a repeat from a previous one, they'll just call it a C-section.
So if you have a C-section, I feel like there's like mixed things. Are you able to do vaginal afterwards?
Sure you are, but a lot of providers don't advertise that.
I was gonna say, they told my sister she could.
Well, and what I heard, so Cap Region, for example, well, actually both hospitals here do not always have an obstetrician in-house.
Yeah.
When I worked at Boone, we did, and it was really nice, but here I think they have to be like within 10 or 15 minutes away. So like at Cap Region, they will let them do a trial of labor, but it has to be 8 to 5 Monday through Friday, which I think is hilarious. But the reason they're specific is because the ACOG guidelines are that if you are going to let someone do a trial of labor after having a C-section, you need to have anesthesia available as well, because you have to be prepared for a stat C-section. And so a lot of times, I've also heard that some anesthesiologists are the ones that don't want to be part of those deliveries. It's not necessarily obstetrician. So, but the guideline is that if you've only had 1 or 2 C-sections, you should be offered. What I typically see is if there's 1 previous C-section.
So
And it has to be low transverse.
I was gonna say,
Cannot
does
be-
it depend on how they
Yes.
suture you, and does it
Yes.
depend on how long it's been as well?
I haven't heard it depend on how long it's been.
Okay.
And also keep in mind, the skin incision may be different than the uterine one.
Okay.
So they have to have documentation, because we've had some patients from other countries who had C-sections, and unless they have documentation of what kind it was, the providers won't. Yeah. So, good questions. All right, so what's a fundus? What?
Is it the top portion of the uterus?
Yep, it's the top part of the uterus. Usually when you hear fundus, it's gonna be in reference to a postpartum mom.
Mhm.
Sometimes I'll hear them talk about it like during pregnancy, but I don't think that's,
I always was like referred like the fundal height when
Yeah.
you're measuring.
Mhm.
That's
bundle height they might say, but I feel like when they use the term fundus, we usually are talking about it, yeah. Now technically, guys, I don't know if you've noticed this, there's several body parts that have similar names. So have you heard that, like, this is our cervical spine? The cervix of the female reproductive, it's the neck of the uterus. So cervix, cervical cancer, it's down to the cervical, but that's 2 similar names. And then I brought that up because we think of fundus in OB as the top of the uterus, but there's a part of the eyeball called the fundus, and it's like a globular shape. So fundus often refers to globe-shaped body parts. Okay, what's the difference between a laceration and an episiotomy?
Episiotomy is done on purpose, and a laceration is just something that
Mhm.
happens during labor.
Correct. So an episiotomy is actually considered a minor surgical procedure. It's very minor, but it is a procedure. And then the laceration is exactly like it sounds like. That's when the body tears at a natural point. And you'll hear different schools of thought from different providers. Some believe that if you know that she's going to tear, if you can tell she's going to, go ahead and do a nice clean cut, because it's nicer to stitch up. Other schools of thought say let it tear at the path of least resistance and then sew it up. So, I would say in general, there's been far less use of episiotomies. Far less routine use of episiotomies than there used to be. A lot of providers used to be trained to just do one on all moms, and I don't think that's the case anymore.
How common would you say that laceration actually is?
Very.
I figured it was, but
It's always funny because when we talk about this, I always see the girls like thinking that sounds awful, and I'm like, oh, it happens all the time. We rate them or grade them 1st degree to 4th degree, and I would say 1st and 2nd degree, 50% or more of deliveries have. And those are, I don't want to minimize it, but those are nothing.
and those get stitched up as well.
Some moms will ask not to, but most of the time they'll just stitch them up, and it's very minimal.
Why would you ask like not to stitch it up?
Well, there's lots of people that like to do things more natural. They like to keep their placenta, they like no epidurals, they want things to heal on its own. And I shouldn't be lumping all of those things together, but it's just some people would rather be less invasive, were you gonna ask how common they are?
Yeah.
Okay.
I
And then there's a handful of moms that push out giant babies and don't tear. So a lot of it, I do think, has to do with genetic components of connective tissue. So,
I feel like it's more common, like I did with my first, but not my second too.
With the first baby.
I honestly don't know, cause I mean, that makes sense, but
Well, and I was like, it was one stitch, it was like
Yeah.
barely a 1 degree.
yeah, I don't, that would make sense, but now that you asked that question, I don't know that I can definitively say, yes, we know women take, we know labors are shorter with subsequent labors generally, but I don't necessarily know that. Baby size also can affect it, or how fast they deliver. I've seen some people just deliver so quickly, I don't think the tissue got a chance to like, yeah, so, anyways, okay, so, we'll spend quite a while on number 3, and hopefully everyone understood the instructions, but there was a chart in chapter 19 that kind of went over what the normals are for these parts of the body, and what some of the deviations from normal would look like. I really like to advocate, I used to teach health assessment, and when I taught farm, I was really big about, and I hope you guys are too, that what is the first step of the nursing process? Nursing process. Yes. Alright, we're gonna focus on that this semester. Okay, why is it assessment?
That's your baseline.
Yes, and I like to tell people you have to do that well or you mess up the rest of it, right? If you don't have a good assessment, how can you possibly make a good plan of care and nursing diagnoses and intervene if you don't have a good starting point of understanding what you're dealing with? So in this course, in this section of the course, yes, we are mostly dealing with healthy women, but that doesn't mean we don't assess them thoroughly. Okay? This is a great class to practice your assessment skills and making them even, fine-tuning them even more. So when we do a head-to-toe assessment on moms, it is gonna look a little bit different than your med-surg assessments. You will still use your stethoscope for heart, lungs, bowel sounds. We typically look at legs for edema. We usually do reflexes, like patellar, deep tendon reflexes. I don't really see us do pedal pulses much. I mean, if you do them, it's not wrong, but you probably won't see OB nurses do pedal pulses.
So majority, pulses.
How exactly do you
Gastric.
like listen to the abdomen?
Oh, I can show you this.
Is it
all
just
four
like
quadrants
you
and-
still do, cause
Oh yeah, I mean, you lay them flat. You mean because of where their belly button is? Or
no, I just mean like you'll just be with my babies, they all go right here. So
Oh, well, we're talking about postpartum.
Oh, okay.
Yeah, this is
Okay.
the focus today is postpartum.
Okay, I thought you
I was
meant
like-
admitting a new, like a delivery
No,
mom.
so
Like, I don't remember
today's
anyone ever
focus,
listening to my baby.
Postpartum.
Okay.
Yes. I'm not really gonna talk a whole lot today about laboring patients, but we'll get to that. This is also because when you guys do hands-on care in OB, it's mainly gonna be with the postpartum moms and the newborns. When you're doing labor and delivery, you're gonna be observing. So this is the stuff you'll be touching more and doing. So that's why we're kind of doing a crash course before clinical start. And then it'll augment what we talk about next week in lecture. Okay, so then what we add to the normal head to toe are a couple of things you're probably not used to deeply assessing on med-surg patients. So one is breasts, one is uterus, and then we'll definitely look at her perineal area, and then we'll assess her fundus. So we'll add those OB components to our already head to toe assessment. Okay, any questions so far? Okay. So I'm just gonna start, since we have it in that bubble key order, let's just start with the first one, which is breasts. Okay, so how much fun is it gonna be to talk about breasts? So what did you find that are normals, and we're talking about a postpartum mom, normals for what you would find on her assessment in the first few days after having a baby?
It should sound clear to auscultation.
Her breasts?
Maybe not.
Maybe I was
Stephanie, you're the first person who's ever answered that, and I love it. Do not put your stethoscope on anybody's breast.
My bad. They should be soft.
So I'm learning. Within
I'm gonna exit
15
that out.
minutes, that assessment might be something we need to work on in this class.
I didn't even read it when I said that out loud.
You know what? But you answered. That's what we need.
But I do have that they should be soft 1 to 2 days.
Okay,
postpartum.
so soft and clear to auscultation.
Yeah, it should sound good.
Yeah, they should sound good. Okay, so do not put a stethoscope on a woman's breast. Please do not do that. They should be soft. What else?
The skin is intact and there's no soreness reported.
Okay, so we're hoping no soreness, no skin breaking. Okay, so if they're supposed to be soft at first, when does that start to change, or what do we tell them?
2 to 3 days.
Yes, usually around 2 to 3 days, they will start feeling like their breast consistency is changing, getting more firm, and then you'll often hear moms say, "Oh, my milk came in." Now, that is somewhat of a misleading statement. Why? First of all, we know what she means, but why is it a misleading statement? There was already milk there. What they're talking about is that mature milk and larger volumes are coming in, but there was already milk there. It just wasn't as prominent as far as filling her up. Okay, so usually somewhere between 2 to 3 days, if she's lucky. Sometimes it's a little later than that. Her milk will come in, and then what are her breasts gonna feel like?
3 to 5 they'll be full.
They'll be full, and guys, when milk actually truly hits, when that first really hits, they can be literally rock hard. And until you have felt that on someone, it doesn't to me seem like a human thing. I'm like, yeah, right. Until you actually either feel it on yourself or help a patient try to pump or something with rock hard breasts. Okay, so it does hurt. They'll often call that engorgement when a woman experiences that feeling. Keep in mind that's not all milk. Some of that's just swelling. Okay. Okay. So somebody said they should be non-tender. So is that the going statement? It's never painful, or what amount of pain, if any, is normal? What do we tell them? They should never have pain, or what info do we give them?
Like well breastfeeding?
Either. Yeah, just in their first few weeks.
Minimal.
Extreme pain.
They should never have extreme pain.
Tenderness is normal.
So typically, what we say is that it is normal to have mild discomfort for the first week. Okay. Why do you think we should expect that some women are going to have mild discomfort for the first week if the other side will say, but breastfeeding is natural, it shouldn't hurt. It's a natural process. I don't know why you're having problems.
We need to change the mature milk. It's changed the composition, so it's taking up more room inside the.
Okay, so the breast tissue's going through a lot just from stretching and filling up more. Okay.
Your nipples are going through a lot. So.
Yeah, they are. What do you mean by that?
Like with my sister, my nephew would just like latch on and turn away and pull it.
Oh.
Like I literally watched that just go
Like
so
bite
far.
and then yeah.
Yeah, he just turned around and
Like
be
a
like
chew
over
toy.
here.
Yeah. Yes. So that was probably when he was a little older, like when he was moving around more.
A few months, yeah.
Yeah, gets busier. Okay, yes, that's correct. So what I like to tell people is that we expect some discomfort because first of all, how often do babies feed?
Every 2 to 3 hours.
Every 2 to 3 hours, which would then equate to how many times a day?
10 to 12.
Close.
I don't remember.
Every 2 hours goes into 24. 12. Every 3 hours goes into 24.
Eight.
Gosh. Yeah, wait for the math.
3 goes to me, 12, is that what you said?
24. How many times does 3 go into 24?
8.
Three? No, 3 times, never mind, I'm done.
Eight.
Do you guys have flashcards? Like
It's 8.
yes! 8 to 12 times in 24 hours.
I said that, I thought I was wrong, cause you were still making me
Well,
answer.
there was also a bunch of different numbers coming from all different directions. So every 2 to 3 hours, 2 and 3 both go into 24 perfectly, equates to 8 to 12 times. Okay, that was painful. So if they're feeding every, or 8 to 12 times a day, and how long does a general breastfeeding session last, generally?
Like 45 minutes, it's 15 to
That's-
20.
Yeah, 45 is probably a little, like right around, yeah, somewhere around 25 to 40 minutes or so. They'll usually do 15 or 20 minutes on each side, generally. Okay, so let's think about that. 8 to 12 times a day for at least 20 minutes per nipple. This is what's going on. A baby's suck is strong. There's usually no air getting through, so it's like friction. So I like to tell people that most women's nipples are not getting that much use before breastfeeding. I can't say that about all women. There's different professions that may require her to do that. But most people aren't having that happen. They're not having that much traffic per se. So of course it makes sense that if you then put a baby, which is a giant suction cup, on each one 8 to 12 times a day, there's going to be some transition in comfort. So but the key is it's mild, and we're expecting it may be while the baby's latching, like just getting the nipple to the back of the mouth, and then maybe just a little bit in between if she's just getting used to that feeling or the bra against her skin. But it should not ever be moderate to strong pain, and there shouldn't be any skin breakage, blisters, and bleeding. Now, if those things occur, when I say those shouldn't happen, that doesn't mean she's doing something wrong. What it means is that we as nurses need to help her not get to that point. And if she's got something like that going on, we need to help her and refer her. Okay? Not until you've gone through it yourself do you realize how incredibly painful it can be to have a wound on a nipple that is needing to be suctioned 8 to 12 times a day. When does it heal? Okay, so we want to help catch things early and intervene early. Now, what do they think, or what's the belief that is the major cause of nipple trauma, nipple issues? Bad latch. We usually call that breastfeeding mechanics. So if there's something wrong with the latch, the suck, the swallow, the hold, if the mechanics of the setup aren't good, that is what is believed to be the #1 cause of pain and skin breakdown. So what do you think is the first step to helping somebody?
Teaching them the correct. After first.
No, go ahead.
Teaching them the correct way.
Yes,
Supporting
which
the
we
body.
should do anyways, but especially if someone's reporting discomfort or pain or they're starting to get a blister, the first thing we need to do is assess the suck, swallow setup of what's going on. And I hate to tell you guys this, but after you leave today, you're gonna get volunteered to help with breastfeeding. A lot of people want to try to say, oh, I can't do that, I'll go get someone else. But you don't have to have breastfed yourself to be able to help. You'll have enough information to at least help, and then to seek out more information if needed. So remember, the baby's gonna be your patient too, and we need to make sure that it eats. Okay, so if we're helping a mom breastfeed and she does not really know much about it, or it's her first baby and she just has no clue how to do it, and we want to help her get a good setup and a good latch and good mechanics going, what kinds of things are we going to teach her, tell her? How are we going to, if she's my patient and is like, I have no idea what I'm doing, what am I going to say, do, etc. to help her get set up to breastfeed her child?
How to properly place the nipple in the infant's mouth.
Okay, that's definitely an important part,
Or
right?
just before that, finding a posture that's comfortable for her.
Okay, perfect. So I think one of the things I had you guys do was be able to tell me or show me those 4 classic positions. Isn't that what I have at the very end, right before the article? It says to know how, did you guys look at that part? Everyone?
Review the position and watch.
Oh, I was gonna come to one of these ladies, but you want the first? Alright, I'm not gonna turn you down. Alright, will you pick one of the positions and demonstrate how that hold would look?
Used to be like this.
Yeah. And which, do you know the name of that hold you're trying to do?
No, I don't remember.
Okay, I'm gonna, yes. Who
I
said
think I
that?
say football.
I wanna put this maybe through your arm.
Oh, it goes through.
There you go.
Okay.
Yep.
That's all.
So that's why it's called football. Do you guys see him?
Yeah.
Okay. So that's the football hold. Okay. Good job. That is a great position with new families in the hospital. What's the classic position that we think of? This is what all the pictures in the book and on, pretty maternity books are gonna show you breastfeeding like this. Most brand newborns, when you put them like this, what do you think they do? Oh, and it smells like my mom and it sounds like her heart. They get way too comfortable. Remember, there's gonna be colostrum, but colostrum there's not a lot of volume. It's got tons of protein and tons of fat and tons of calories, but there's not a lot of volume. So they're gonna lay down here and be like, I'm just gonna take a nap. The football hold is very helpful. Why? It's not as cozy for them. Look at what control I have here. The head. And then as a new mom who's still learning, I have great view. I can view myself well. Like I've got this other free hand so I can help myself get arranged. And that can be very helpful. Okay, so football hold. Olivia mentioned making sure they're comfortable. They have, they're in a comfortable position. Use the bed to your advantage if they want to sit up higher or adjust it, and then don't forget the importance of pillows. You can't have enough pillows. Okay, I was gonna go to you guys. You gonna do another position?
The other one I saw in the book was like side laying.
Yes.
She's like laying on her
It's
side.
kind of hard for her to demonstrate.
Yeah,
Yes.
like she's on a bed and like on
Yes.
her side.
Yes, and so literally what they say with that one, it's hard to demonstrate in the chair. The bodies are gonna align. So if mom's on her side, baby's on its side. They're facing each other. And so who do you think that would be helpful for in the hospital?
The moms are just on epidural.
Yeah. Who's C-section. So if they still have, what'd you say?
Never mind, that was a dumb answer.
It was not a dumb answer.
Did you hear mine?
That one's gonna be hard
You
to top.
might have won.
If you see that and while you're grading, just ignore it.
No, honestly, I don't know if this is gonna make sense to you guys, but the longer I teach, it's harder to surprise me. So when a new group asks a question no one else has or gives an answer I've never had, it's fun. And it's even funnier after it took you guys 5 minutes to answer what's the first step of the nursing
That
process.
too.
It was really just like the cherry on
That
top.
chart had all of them in a row, and I think that it
They
probably
were
had it
probably
right
in your
above
butt.
it, and I saw it. I'm
Okay, this is how we learn.
We learned what not to do now.
Yeah.
I am gonna tell Lauren though that I did tell you guys not to put your stethoscopes on somebody's breast, just so that she knows I didn't teach that. Okay, so you were on the right track, and then you added to it. So anybody who's still under heavy effects of anesthesia, and it's usually gonna be our moms who had C-sections. Usually if they have an epidural for a labor, it's gonna be kind of from here down. So after delivery, they're gonna be able to kind of shift in bed and sit up just fine. With spinals or epidurals, they have to dose way heavier, it's gonna go up higher. So there's a bigger blood pressure problem when you start to set them up. And so they may get dizzy or sick, or it may just be too fresh. But if that baby is rooting around like crazy, you wanna help him feed good the first time. And so a lot of times we'll just tilt those moms over to their side, put a bunch of pillows behind them, and help the baby breastfeed in the sideline. Do you think you can do the last one? Remember, it's always hard to be the last one.
I think it was kind of like the football position where it was like this.
Yeah, you're right. You did very good. So it's kind of like the football mixed with the cradle hold,
Yeah.
and they call it the cross cradle. So you can think of it like the regular cradle, I'm feeding off of the same side I'm holding with. So I'm holding my baby with my left arm, he's eating off the left side. Cross cradle is the opposite. You leave the baby in the same place, but you're holding it the opposite way. And some people like this, because the legs will kind of go down here, but then they have their hand right here to be able to maneuver themselves or handle themselves. So, good job, guys. Thank you. Okay, so we talked about some basic positions. What other things did we learn so far about helping them get ready to breastfeed? What other things should we do? Okay.
Knowing like the cues that the baby will show.
Yeah. Is it hungry? And yes. And we don't want to wait till it's late signs of hunger.
Screaming.
It is no fun, and it's almost pointless to try to help a crying baby to breastfeed. They're so angry that you ignored them that they're not going to feed well. And then guess what happens? What do you think happens?
The mom gets frustrated and doesn't want to do it.
And thinks they're a bad mom, and they're going to start crying, and the world's going to end, and they're horrible, and they can't do this, and all these things that postpartum hormones make you think. So watch the babies. If they're sleeping, but you're seeing them go, or they're putting stuff by their mouth, or they're doing that, sorry, it's not at lunch. Those are early signs. Ask how long it's been since they've fed, or look at your notes or whatever. If it's time to eat, and they're making those early signs, what I will often do is tell the parents, and then I'll go ahead and do something like check the diaper, because that usually kind of wakes them up, and then I'll help them. That is a much better time than waiting till they're angry. Okay, the other thing is, I think Kyrie said we want to make sure the mom understands how to latch, like what we're going for. So what are some basics that you've learned so far from doing some of your homework of what a good latch would look like?
Where like the top and bottom lips are completely folded out.
Yes, so you do want the lips to kind of look like a fish.
Yeah.
Okay? You do not want them going like this. Because then once they get teeth, they're gonna bite themselves. But you want their lips, it's called flanged out.
Do you hear the baby swallow?
Yeah, sometimes you'll hear it swallow. That's a good sign, correct?
You don't want to just on the nipple.
Yes.
Have it open her mouth completely.
Our guest speaker that we're gonna have next week will always say it's not nipple feeding, it's breastfeeding. But I think a lot of people that aren't familiar with it just think of the nipple, they think of it as like the spout. You just have to, like a straw, and it's not that way. That's not how the nipple functions. So you're going to tell the mom, and you're gonna help with this as well. The nipple's gonna be in the back of the mouth. So that baby's gonna have a good portion of the areola also in its mouth. Okay. Anything else?
You don't want to hear air.
Right. You don't want to see the cheeks like sucking because there's air going in and out. You want a good solid seal. Okay. The other really big thing to keep in mind is that the mom needs to be comfortable, and she needs to bring the baby to her. I kid you not, because moms love their babies so much And if the baby's screaming and she wants to be successful, she will take her body and do whatever to get it to breastfeed. And if this is how it works, she'll stop and do that. And what do you think's the problem with this?
She's not gonna sit like that for 20 minutes at least.
Well, sure, the baby's eating, she's fine.
Well,
What do you think the problem is?
What if her arm got tired and, you know, you just never know.
Sure. What else? What else is the problem with what I'm doing here?
There's no. She's leaning over the baby.
That's true. There's no support. Yes.
Does
Can
she
they
have a
breathe
C-section?
Good question. Usually, if they're sucking, they can breathe.
Okay.
But that's a good thought because it does look like I'm smothering this child. Yes.
The mother is not comfortable.
Correct. And what's going to happen right now? She's running off endorphins, right? And she wants to succeed as a mother, and this is how she's going to do it in her mind. So she, at this moment, thinks, yeah, I'll do this. It's no problem. But we know what's going to happen if we let her do this.
She's gonna get tired.
Oh my God, she's going to hurt so bad. Musculoskeletal pain. Tomorrow is going to be awful, and she probably just pushed for a few hours to get a baby out. It's not going to be pretty. So, sometimes when I walk in to help moms and they're doing that, and the baby's going crazy and she's crying, I will say, could I take the baby for just a second? Do you mind? And if they have a pacifier already, I'll say, do you mind if I use this? And I'll calm the baby down. And then I'll ask her, can you readjust so you're comfortable? You know, so she might need to scoot up in the bed, she might sit up, I'll get some pillows. And then when she's comfortable, then I'll say, okay, what positions have you used so far? Or has any, and if they don't know anything, I'll say, I'd like to try the football hold with you. Is that okay? And a lot of times they're like, whatever, just, yeah, that's fine, whatever. I don't know anything, I don't know what I'm doing. Or she might say, I don't like the football, I want to do the front hold. Okay, let's do that. But then you're gonna teach her whatever she gets okay with. Let's say she's okay with the football. You're gonna teach her, okay, I'm going to put the baby into your arms, but I want you to bring the baby to your body. We do not take the body down to the baby, okay? And once you show them that, that usually helps tremendously to get them to calm. See, she didn't like the football.
That's
She
right.
likes the-
Yeah.
Oh, she likes the cross training. You're right. Good job, Stephanie.
Fine.
Do you want to listen to our Okay, so does that make sense? A lot of these things are so simple, but the moms don't necessarily know, and it is stressful.
There's a lot more probably going through their mind at that point.
There is.
How to
Yep.
hold the baby.
I was literally just talking today on the way to work. My mom called, and my husband's, our twin niece and nephew just had surgery for atrial septal defect. They've had since they were born. They're like almost 6. But I was telling my mom, like, oh yeah, my daughter Madeline, they thought she had that. We had this ultrasound in the hospital. You know, she's like, did I know about that? And I said, no, I probably didn't tell you because you would freak out. But I remember having postpartum blues, like, in the hospital, and I sobbed and sobbed because of that ultrasound that they were doing in her heart. Because I thought I did something wrong. And then, because I teach this stuff, I was like, Abby, you're being silly. That's dumb. And then I cried harder because it was stupid. Like, it's a cyclical thing. And so sometimes when you're in there helping, everything will seemingly go well, and they might just start crying. And it doesn't mean you did anything. And then they know that, you know, so just be prepared that you may see some of that. But for some reason, I think a lot of moms attribute things that aren't going well, that it must be something they did wrong. Even if breastfeeding is going great, but the milk component's not coming through like it should, they think they did something wrong. They're a bad mom. And that's not the case. So I'll talk about this in lecture next week, but while we're already bringing it up, you may hear, if I'm ever in clinicals with you, or you may hear Lauren do this, or the nurses, if you ever see a mom that you can tell needs some uplifting, or you see something that they did well, it's okay to compliment that. You know, sometimes I have teenage couples and they're very young and they're very inexperienced. But if I see them do things like, oh, she's eating her hands, she must be hungry. If they pick up on things like that, I'll say, good job picking up on those hunger cues. Good job reading your baby, you're right. I'm glad she's not getting to the point of crying. You did a great job with that. Even if breastfeeding's not going that great, tell them what is going well. You're doing a really good job just staying calm and being patient with this. I know this is a lot. The first few weeks are definitely the hardest. You know, that kind of stuff. It goes a long way. Okay, so we talked about normals for breastfeeding positions. Let's talk about, so what did we talk about as abnormal on the breast itself? What would be abnormal if we saw it? Or she told us sores. Okay. What else? Redness?
Like,
Mastitis.
Oh, well, engorgement can sometimes make the breast feel kind of lumpy.
Yeah.
And that's not necessarily a bad thing as long as milk is coming out. They can get, I bet you're thinking of a plugged duct. They
I
can get a
think
plugged
so,
duct, yeah. And we'll talk about that part later.
it's really painful like that.
Painful, yeah. What else would be on a postpartum mom, if she's reporting it to us or we're seeing it, would we consider it?
Blood.
Yeah, if they're bleeding,
Or if the skin's cracked.
skin's cracked, yep, severe pain, moderate pain. Those are all things I don't wanna say we don't wanna say, oh, that's bad, because then she's gonna think she's doing bad. Those are things that need intervention right away. Okay, so when we think pain and nipple trauma, what's the first thing we should be thinking on our care plan? A breastfeeding mechanics assessment. Let's look at how things are going, and then if there's a lactation consultant on staff, we definitely want to make sure that lactation consultant is visiting. But if you work night shift, you don't get to say, I'll have the lactation consultant.
Does
see you."
every hospital have a breastfeeding consultant?
All the ones around here do.
Okay, I was gonna say, cause I know I've seen them at St. Mary's.
Yeah, St. Mary's and CAT both do, and then the Columbia ones do. The problem is they don't work 24/7. So, a lot of the stuff I keep teaching from year to year about breastfeeding, I do because the students learn a lot. I've had several students who were techs in ERs help more with moms that came in with bleeding nipples than the staff could. And it was somebody who delivered like on a Friday night, we went home on Sunday, so they never saw a lactation consultant because they don't work on the weekend. So, and a lot of people that don't work in OB don't really don't know a lot about it, yeah. So, okay, so yes, they all around here do have one, but they don't work all the time. So, especially if they deliver on the weekend or in the evening, or the lactation consultant's out for some reason, they may not see one. Which is why any maternal child health nurse should be able to assist with breastfeeding. If you work in a non-maternal child area, if you work at a health department or somewhere else, it's important to know where lactation consultants are at so you can refer them. If the patients deliver in these hospitals, they can come back afterwards to see the lactation consultants. The one for Cap Region is actually stationed at their pediatrics office. She just goes over to the hospital as well. But we also have one at the Whaley's pharmacy here in town, and then in Columbia, they have one with Kilgore's.
I heard that on the radio.
Yes. Which is a very wonderful resource to have.
Kilgore's respiratory?
No, Kilgore's was mainly a pharmacy to begin with, and there's several Kilgore's pharmacy locations. And
I worked at a school at Ashland, that's why I was asking, I didn't know that.
Not the Ashland. Didn't
The
they
one in
just get
Columbia.
robbed or something?
Yeah.
Didn't they like cut the
Yeah.
wall? Why?
Did
I
they
don't
steal
know why you would
anything?
know that, but
Oh, yeah.
didn't they take like a scanner or something?
It was a bait bottle,
A what?
a bait bottle,
Bait?
you know, somebody like robs a place, there's like so stupid that was even mentioned, but.
I was intrigued that they cut a hole
Yeah.
in the side of the steel building.
And they
That's
crawled
how they
through.
got in.
We left our door unlocked and that's why it's gonna be broken, but they still act nuts.
Where'd you?
I work at Walgreens in Lynn. They
There's a Walgreens in Lynn?
It's called Lynn Drug, but it's owned by Walgreens.
Okay, because I used to work at the Osage County Health Department. I don't remember Walgreens.
Yeah, they
Is
broke
it,
in.
is it Safeco? That's the, what's the grocery store?
Thriftway.
Thriftway. Okay.
Yeah, so we watched the video. The guy like broke into the York, so we forgot to lock it, and like he was like running around. He was on something. He was like running around and he tripped and he was falling all over the place.
And then
Was he
in the-
making a mess doing it? Like
No,
really?
actually not really. He only went to the pharmacy and then he went into the fridge and there was like medical marijuana in there and he stole like acne lotion.
And not the medical.
That's all he stole.
Did he have acne?
I don't know. He had a hood.
Because
They're like, if you see somebody with a clear face and blue tennis shoes, then that's him.
Wow.
But Kilgore's Pharmacy in Columbia has
Yes.
lactation. I did not.
Yep.
know
Are they
that.
there like all day or how does that work? I couldn't imagine having one.
I think they do like 6-hour days, several days a week.
That's cool.
I just heard, I didn't know if they had it
Is it
either, but then I heard
The
it on the
nurse,
radio.
or is it an actual?
They usually have an actual IVCLC, which are oftentimes RNs, but it doesn't have to be.
I just know that there's a nurse that works, like they're one. of the
They have a
38,
nurse that
but-
does a lot of stuff with prosthetics and other stuff, so I don't know if it's the same person now. They've changed it over the years. My children are getting old, so the ones I know. But there's, like Sally Lepper works for Como Cubs as a P&P. She used to be the lactation consultant.
No, I don't know.
You haven't had children yet though, right?
Yeah, that's true.
But yeah, it's great that there's more community resources, and a lot of them do not charge for the service of the consult. Some do, but a lot of them don't. But what you'll see, because you guys will shadow these lactation consultants, like at Whaley's and Kilgore's, a lot of times they'll recommend some of their supplies there, you know, but a lot of times the actual consultation is either free of charge or very low charge. Okay, so let's talk about if the mom is having nipple trauma, severe pain, bleeding, all that stuff, what we can do. Actually, before we get to that bad point, what are some things you guys, or what's the medication you saw on your med profile that is used? Yes, lanolin. That's a, hey, that was in trouble.
We were all thinking it, so we were.
Channeling through her. Okay, so lanolin is, it's an emollient, so it's kind of like Vaseline. Greasy. And it's a skin protectant.
Doesn't it trap those, like the oil that's produced by the nipple and like helps it?
This actually has origins in wool. So if somebody's allergic to wool, they should not use this. But this can be used preventatively, so prophylactically, or we can use it for mild discomfort.
Do you like recommend everyone just start with it?
A lot of nurses will just go grab this for any breastfeeding mom.
Mild discomfort, or what was the other one?
You can use it prophylactically, so even if she's having no pain and just wants to prevent that, she can use it to sort of prevent some of the tenderness, preventatively. Or if she is already having some mild discomfort, just the normal, this can help with that as well.
Because your nipples get really dried out, because you're having wet sucking and then drying it out, so that helps with just the
And it's a
moisturization.
mouth that has,
Yeah.
its own flora and whatnot, yeah. But if you ever study anatomy quite deeply, the actual glands inside the nipple produce its own, discharge that has like a bactericidal effect as well, but sometimes stuff can still get through. So anyways, if your patient already has this, or you may go get this from the Pyxis with your instructor, how would we tell someone how to use it? This is teaching information from your med profile.
I don't know if I got to that one yet.
Apply a
Convenient.
I don't remember.
Yes, so it's gonna be,
Scholar.
a little bit of this goes a long way, okay? A pea-sized amount can be applied to each nipple.
And then you don't wipe it off.
And you don't have to wipe it off. It's safe for the baby. Some people actually, guys, will use this for chapstick. And some moms will use it for diaper ointment when their baby has.
It works really
So the baby can latch
When
on
you're in the
after.
Yes,
hospital,
but yeah, you don't
and your
have to
lips are
wipe it
really
off.
dry. If no one has anything to give you for your lips,
Get the diaper bag out.
it works really well.
So did everyone hear, you don't have to wipe it off, it's not gonna hurt the baby. A lot of times it's best to put this on after a feeding, so that the next few hours it can kind of be soaking in and doing its job before the next one. It is greasy, so a lot of moms will use like a breast pad between their breast and the ointment just because it can stain. So if you ever see a mom walking around the hallway with like these big, oh, she didn't know. Okay, so that's lanolin. What is something else that we can do or teach moms that is preventative for pain and tissue breakdown and can also be used if they're having mild discomfort? Good guess, but no.
I mean, preventative breaking, how to break the latch, I feel like was really good.
True. Anything else we can teach them to apply to their nipples?
Ice packs, cabbage leaves.
No. What did you say, everybody?
I say honey, but I don't know if it's a program.
Oh, honey. No,
They have
not
these-
here, but if that's something they research, I'd love to see that.
They have these little pads, I can't remember what they're called. the
I
hydro
know what you're thinking. We'll
pads.
get to those, but not yet.
Is it like a salute, like an item or?
That's a tough one. How about this? It's a body fluid.
Breast milk.
Yes.
Oh, yeah.
Yeah.
So the two gold standards, I learned this when I did my master's thesis. If you ever study topical things to help with breastfeeding pain and trauma, the control group always has either lanolin as their item, and then they use the intervention group for whatever they're studying. Or the other thing besides lanolin is you can teach them to express their own milk and rub that into their nipples. So colostrum is very thick. It's actually oily. If you ever look at colostrum in a bottle, it's thick and it looks almost shiny. But it's got a lot of the properties we're talking about. So you can teach them to express their own milk and rub it into their nipples. And that has a lot of magical properties as well. So those two things, lanolin and expressed breast milk, we will recommend to prevent pain and discomfort or to treat mild. But remember, nothing replaces making sure they have good mechanics going on. You still want to do that, but those are things you can teach all moms. Okay, if they somehow get to the point of broken skin, bleeding, severe pain, then we need to up what we're doing, right? So of course we're going to do our referral, our assessment, fix what's the problem. But then we can start adding in some other things. So, I think you guys, somebody was talking about the Soothie gel pads. Okay, I'm gonna pass these around. These can be purchased, you can just look through that. Can be purchased over the counter, but they're little hydrogel dressings. And they can be applied to the nipples.
Do they not have them at
They
the
feed through them.
They do, yeah. What'd you say?
You take them off each time you feed
Yeah,
it.
you take them off and you can reuse them. But a lot of moms will put them in the refrigerator, like while they're feeding. And then when they put them back on afterwards, it feels really good to have not just the hydrogel dressing, but,
Is this to treat the symptoms or treat the actual?
it's more to
Does it
treat
have
the
any-
symptom. It's more for comfort.
Okay.
Yeah, good question. They have not yet created a perfect dressing to fix the symptoms.
I think they're on. No, these are like a gel, like, the ones I had were actually a square, not a circle.
It's probably just a different brand, yeah.
But
Okay, do you have your hand up or are you just stretching?
Just-
Okay. The other thing that you'll sometimes hear about is, there's something called all-purpose nipple ointment. APNO, all-purpose nipple ointment. Okay, so let's talk about if somebody's got painful, broken skin on their nipples, it hurts, it's inflamed. What do we think's causing that? Perhaps the poor mechanics caused the skin break, but if it's hurting still and the skin's inflamed and the infection. So what could be infecting?
Mess.
What?
I was gonna say mastitis.
Thank you. This can lead to mastitis, but we're not there quite yet. What could actually be infecting the nipple skin?
The saliva from the baby.
Okay, and what could be the causative agent? Generally, just what critters are we talking about? Bacteria.
Oh, yeah.
Okay, so bacteria is one possibility, right? That's a common infection, right? What's another common infection, especially with the babies?
Fungal?
Fungal, yes.
Like thrush.
Thrush, yep. So it can be a yeast or a fungus-based issue. So we've got a fungal possibility, we have a bacterial possibility. What's a third thing? It's not an infection, but could be causing severe pain, redness. Okay. It could just be like a dermatitis problem. Some people have very, very sensitive skin and they get rashes and they get angry skin that needs to be calmed down. Some people get like seborrheic dermatitis, skin crevices, that kind of stuff. So, some brilliant lactation specialists years ago decided, what if we don't have time to try to figure out which one of the three of those that is. And we have a baby that needs to eat 8 to 12 times a day. So we gotta attack this problem fast if we're gonna give her any relief and start healing. So the first one I'm gonna pass around is an over-the-counter version of this all-purpose nipple ointment. And it's got hydrocortisone ointment, which is for which issue? Hydrocortisone. The steroid, yep, cortisone. Triple antibiotic for the bacterial component. And then clotrimazole for the yeast, for the fungal. These are all over the counter, and it's got instructions of how you could buy all three, mix them together, and apply it to the nipple. Okay. Oh, you don't have to memorize like which exact meds they are. I just wanted you to know there's an antifungal.
Okay.
I'm sorry. What?
The all-purpose nipple.
Yeah, for the all-purpose, yeah. And this one I'm passing out first is one that lactation consultants may give clients because it's over the counter, okay? The bigger gun, per se, is the prescription strength one. And I like to call him the godfather of modern breastfeeding, Dr. Jack Newman. He came up with this years ago. And it's got prescription strength of 3 different of those items. So it's got mupirocin, betamethasone, and then miconazole powder. And this one, I've seen the doctors here prescribe and the ones in Columbia. This one has to be made at a compounding pharmacy. So Kilgore's is the compounding pharmacy outside of Jeff City, but in Jeff City there's one called the Jefferson City Apothecary, and they make this. So just look over that.
Does it have a like brand name, or do you just?
No, it's it does not have a brand name.
Just send it in as the compound.
Yeah. They have to write the prescription, like the
So when-
exact
yeah.
amounts of each of those.
When would they decide, okay, we need to do the prescription over?
Good question. So I'm just gonna show you guys this. So this is the one I had gotten years ago, but Kilgore's made it, and they just put it in its own tube, and then it has on there like what the 3 items are and how to apply it. You asked when we would know we would need this. If she's having severe pain or broken skin, it would be fitting to offer it to her. I saw a couple of years ago when I was doing clinicals, one of the doctors was discharging a mom, and I think she was already having some breastfeeding pain. So that doctor told her about this stuff and just said, do you want me to go ahead and send in the prescription, or do you just want to let me know? So kind of gave her the option.
Is there ever a time where you would have to use oral, or that should take care of it?
Yeah, they'll definitely do, if they think it's fungal based and ointments are not working or the baby keeps getting thrush and going back and forth, they'll sometimes do oral, like diflucan for the mom. Usually when I see oral antibiotics, it's more the mastitis part, not just the nipple part. And so when we get to the mastitis level, it's gonna be different symptoms. They're usually gonna have a red, warm area somewhere on one or both breasts. They often have a fever. And one of the really telltale signs of mastitis, which I think is very interesting, is they often have full body, what's called myalgia, muscle pain. Their whole body hurts. They have like systemic symptoms, even though the infection is localized. If they say, I feel like I got hit by a car, you know, that kind of stuff, and they're having the other symptoms, that's classic for mastitis.
With the like all-purpose one
Uh-huh.
and the prescription, do you have to wipe that off before you breastfeed?
You know, for a while they said you should. Lately what I've been seeing is that they say that these are not meds that can be absorbed by the GI tract anyways, so it's kind of pointless too. So, which just
Yeah, I
shows
feel like even if you wipe it off, you're almost still gonna have it.
yeah, you're still gonna have some, yeah, but I've even seen people say, why wipe it off? It's not absorbed through the GI tract. So it shows you how often things change. I didn't tell you guys the funniest part of this that always makes people laugh. So in research, the official name is all-purpose nipple ointment. You'll often hear us call it triple nipple cream because it's got the triple approach. But my husband always said, that sounds like you have 3 nipples. So, but you'll hear
How do
people
they
say,
write it on your label?
they did not write triple nipple, I know that. Oh, they have a little sticker. Billboard sticker, see? Tyrus and 2%. So they already have that.
It is called triple breast nipple.
Oh, it does say triple.
That's the name
You
of
know,
it.
it does say that. I'm so sorry. I was in denial, I guess.
I was gonna say, I'm pretty sure I've seen
Yeah.
the triple nipple actually on a prescription. So that's why I
You
didn't know
have.
if it was.
You have seen that. You're right. Obviously, you guys know you're not gonna yourselves be just giving this out or prescribing. I want you to be aware of kind of what's out there, and then especially if you feel like a mom's not getting relief or is not being listened to, that we need to advocate for her getting more help, etc. Okay, you may see, you mentioned a nipple shield earlier, right? You may have patients that have what's called a soft shield. I think it looks like a sombrero. If they have one of these, first of all, you'll never get one of these for a patient. You'll never start them on wounds. But you need to know how to use it if your patient has one. What do you suppose they would use one of these for? You can all tell where this goes, right?
Yeah.
What might be a reason? And notice there's these holes in the end.
Trouble latching and getting ready.
A lot of times, so where they really came from is that, you know how I told you guys we're going to learn that there's lots of varieties of anatomy. Some women have what's called flat nipples, like truly flat nipples. Everything looks the same, but their nipple does not erect. And then some women have what's called an inverted nipple, truly inverted, where it looks as if you took like a pencil and pushed them in and they stayed. So those babies have a really hard time, if she's got inverted nipples or flat nipples, of having anything to latch onto. So this sort of thing can help with that tremendously. Who else might need one of these? Or when else might we use one?
Can you use it as a skin barrier if it's like,
Yes. Sometimes if they're having like severe pain and like just awful, they'll sometimes recommend something like this because it takes the friction right off of the wound. And it still isn't comfortable, but it's better than putting the baby directly onto it. If it's really bad, sometimes they'll just have the mom pump and then bottle feed it if it's hurting too much to directly breastfeed. Also, please make sure you guys know that what we're talking about, a lot of these issues are outliers. It is not common that women have bleeding nipples from breastfeeding. That is very rare, but it does happen.
Yeah, I was like, oh, I don't ever want to
No, yeah. Many women don't have hardly any troubles. It's just getting used to the baby, feeding, okay, milk's in, oh, they're gaining weight, that kind of stuff.
So I don't know if this goes with this, but like, what happens if they're in the hospital and they're having problems producing the milk? What, is there anything?
So usually, like a vaginal delivery, they go home on the second day. So a lot of times,
We don't do, yeah.
now especially breastfeeding babies, the pediatricians will want to see them like the day after they leave the hospital, or maybe 2 days. They'll base that on how the weight's been going.
So will you really be dealing with breastfeeding then?
You'll definitely be dealing with breastfeeding.
'Cause a
You
lot of
just
the
may not be
colostrum-
dealing with like the mastitis because
part
the
of
milk
it,
came in
Yeah.
or the pumping as much.
Okay.
Yeah. But as you will learn soon, if you haven't already, remember that breastfeeding is a positive feedback mechanism. So the more you empty the breast, the more her body knows to make more. Which is why, even though it's not going to be pouring out of her like it will be later, we have to keep these babies feeding many times a day so her body knows, hey, you got a baby to feed 8 to 12 times a day. Oh, he's back for more, make more, that kind of thing. Okay, so somebody said the skin or tissue problems, inverted nipples. The other place I really see these used a lot is in NICUs. When it's a baby who hasn't breastfed yet, they've been mainly on like tube feedings or bottle fed, they'll often use this to transition them to breastfeeding because it's just a little easier at first. When they're in the NICU, they don't like them to use a lot of energy to have a feed, and then they'll try to wean off of this. But you will never be starting one of these, you just need to know how to use it. Typically when I have a patient that already has one of these, they have it somewhere like on the bedside table or over by the sink, I'll just put on gloves and go wash it off or get it wet, because it usually kind of sticks a little bit better.
And it can reuse that same one?
Yes.
You don't have to worry about like bacteria?
Most of them have like a case that it goes in when you're not using it.
And think about pacifiers
That's true.
and bottles. They don't really sterilize things like they used to say that we should. Any questions? Yes. Okay. Another thing this is the soft shield. Another thing you may encounter is there's something called breast shells. So these are harder. I don't really see people use these a lot, but sometimes you'll hear about them. So it's got the shell part, and then you can change out the inside part. So this one, where it looks like kind of like a inner tube, some moms will use this if they're having really bad like nipple issues and they're using that triple nipple ointment and maybe their bra it's hurting. They'll put this on to prevent rubbing, and it's got these holes because especially if it's like a thrush fungal issue, we know that bacteria and fungi like dark, warm, wet environments. So putting these holes helps with airflow. Thank you. Does that make sense? Yeah, airflow, so it can help reduce the buildup of bacteria. See the holes
Oh,
in there?
okay.
Yeah. Okay. The other, it's got these things can change out, so you can pop out the inner tube looking one and use this thicker one. So for a while, like in the 80s and 90s, there was this real big movement that if a mom had really, really flat nipples or inverted, that she could wear these during pregnancy as like counter pressure. Because if the bra is holding this in, it's gonna push her nipple through and help erect the nipple tissue. So some women will still utilize
Does it
that.
work?
I don't feel like that. I feel like in healthcare we do a lot of things that make sense, but I don't think the research is there that really proves that it works. Yeah. There's a lot of neat research from like the 80s. They used to try to use towels to like toughen up the nipples before, like they thought that was gonna prevent like nipple trauma and get them ready. And I was like, that sounds barbaric. they used to, like now we do moist wound healing, right? They used to use like hair dryers and stuff and use, and I'm like, why? You know.
I know now it seems crazy, but back then they thought it was like the
Yeah,
best thing
I mean,
ever.
yeah,
It's
and then,
crazy
so,
about.
but yeah, it's just interesting. So to me, these are, I mean, it's a nice idea. I'm sure some people think they're great, but I haven't personally seen actual good research showing, oh, women that use these breastfed this much longer, you know, compared to not. But okay, any questions thus far about breast normal findings and then breast supplies? The other thing you may see is a lot of moms will have breast pads, or they'll ask you, do you guys have breast pads? And I think they look just like menstrual pads, but in a circle. Okay, why do you think they have these? First of all, these are not required. Nobody has to wear these.
For leaking.
Leaking. What else?
Do they also stop friction in clothing?
Yeah, some people would prefer to have this against them than like their bra.
When you let down on one side, the other side also does it
Yes.
at the same time, so you'll
It's
have
so
this, like,
beautiful when that happens.
all of this milk on one side,
Yeah.
so it's nice to have that in on the other side, so
Yes.
there's not milk all over your bra.
And then remember how I said lanolin's really greasy? Some people will wear these just so the lanolin doesn't stain their clothing. When Lauren gives you guys a tour, just make sure you find out like what supplies are carried for the patients. Every hospital I've worked at, some provide these, some don't. Some have the Soothie gel pads, some don't. So just find out what is available that you are allowed to get out and what is not. Okay. Why don't you guys, I just realized, why don't you guys take like a 5-minute break? Just,
You're doing a great job, by the way.
participating So uterus and lochia. What did you find for what some normals are that we can expect when we're assessing our hospitalized postpartum patients? What?
Well, directly like after delivery within the first 2 hours, when you look at the baby, and then it should slowly decrease.
It will be relatively moderate as far as how heavy it is, but yes, it is a good description to tell a patient is it will be like a heavy period at first, and then it'll start to taper off.
And can't there be like blood clots in the first?
Yes, there can be blood clots.
It starts out like really red and then
Yes,
it stays
the color
on it.
changes. Yes. And before we delve more into like what's normal with lochia, what is lochia? What is it?
From the placenta, it's the blood and
Okay.
feelings of your uterus coming.
Yeah, it's all sorts of stuff. Were you gonna say
Oh, I
something?
say it's a mix.
What?
I say it's a mix.
It is a mix. Yeah, there's blood mixed in there, debris. There's like the amniotic fluid sac. The base of where the placenta is, that as that heals, there's deciduous cells that come up. You know, it's healing. There's lots of white blood cells mixed in there.
Is
Lots.
everything left over from birth?
It's not left over. So let's talk about that. You said the word placenta. So what did you mean by that?
Well, so the placenta is gone. It's what's so the placenta
Or was it
leaves, and
attached?
you have a.
But what is the
wound.
placenta? What was it?
Oh, it was the life.
The life of the baby.
It's the,
The
filter
oxygen, the
between the
nutrition.
mother.
So it is an organ, right, that is attached to the wall of the uterus. And what's a placenta primarily made of?
Blood vessels.
Yes, that is, it is blood vessels. It is a giant, it's almost like burger shaped, blood vessels.
Awesome, I'll remember that.
It's
way
way-
bigger
Well,
than
it works in this agricultural area, if I may equate it to that. Okay, let me just tell you guys, one of the coolest things you can ever look at in clinicals besides a birth is a placenta. They are fascinating. And I always like to give my placenta spiel because one time I was teaching clinicals for Central Methodist, and I don't remember how it came up, but I was helping a student assess a patient, and she was, I don't know if she wasn't like doing the fundal check right, or she just wasn't acting, I can't remember how the conversation came up, but I was trying to get across to her like how easily a mom can bleed out if she hemorrhages, and she didn't understand. She knew what the word placenta was, but I don't think she understood like the physiology. And she's like, oh, I thought it was just like this little plug-in thing, and she just thought it was something little. And I was like, no. By the time you have a term baby, it's like the size of a dinner plate.
Yeah, it's pretty.
It's big,
It's huge.
and it's embedded in the placental, or in the uterine wall, and it's all vessels. So when that tears away like it's supposed to, I think you started to say it earlier, what's left? It is a big, giant, gaping wound. It's huge. And it's in a very vascular organ that for the last 8 or 9 months, the body has worked hard